Hi, doctors. I have read, of course, again, like you said, don't believe everything you read online, but that you can get the medications so much cheaper in other countries like Mexico. Well, we're going on a Mexican cruise soon.
Can I Venmo you?
Somebody going to cue me or do I cue myself?
Cue yourself.
Okay. Hey, everybody. We are back with a new live episode of Let's Talk Off Camera. Before we get started today, we need to give a shout out to our daddy, Andy Cohen. It's his 10-year anniversary of Radio. Andy, we love you, Daddy.
Oh, it's very exciting.
And Lisa, who is in charge of Radio Andy, is here with us in house.
Congratulations.
We go live. Thank you, Lisa. We owe it all to you and to Andy. Now listen, everyone. Listen up and listen up good, because this is going to be, besides our plastic surgery episode, I think this will be the most listened to episode. Okay. We're going to give you the skinny. See what I did there, Jan?
Yes, I did.
If you've tried every diet, every fad, even every workout craze, are GLP-1s the miracle drug everyone's talking about? Are they for you? Or are they just a fleeting trend in the weight loss world? Today, we are cutting the noise and diving deep into science with a true powerhouse. Dr. Fatima Cody Stanford is a leading specialist in obesity medicine, a leading expert on GLP-1s, and she's here to guide us through all of the latest breakthroughs, the potential side effects, and answers you, dear listener, your toughest questions. Dr. Stanford, how are you? Thank you for making time for us. We really appreciate it.
Thanks so much for having me. It is great to be here today.
Okay, so tell us exactly what are GLP-1s. And I did not know this until Jan explained it to me, that GLP-1s are already in our body.
Yes, they are. And I think that's a really important point to start off with, Kelly, because a lot of people think it's just something that we are administering via a shot, via tablets, and we can come back to that a little bit later. But GLP-1s, which stands for glucagon-like peptide 1 receptor agonist, say that 20 times fast, actually exist in our bodies. It's a hormone, a peptide that actually is in our bodies. It helps actually regulate our hunger and satiety signals, okay? So it actually stimulates our anorexigenic pathway in our brain that tells us to eat less and store less, and it down-regulates our orexigenic pathway in our brain. I know those are fancy words. I'm sorry, that's just how I work. I'm a physician scientist. But our anorexigenic, when we hear anorexia, we think, eat less, right? So
right.
For those of us that have more of this in our brain and our bodies and our GI tract, right, where it's also located, you can imagine that those of us that have that on board, we just have innately more of this ability to regulate our hunger signals. Hunger, when we think about hunger, and this is how I ask my patients, is kind of how hungry we feel between meals. Are we constantly thinking about what's the next meal? Are we thinking about not only the meal today, or are we thinking about the meal next week? There's some of my patients that are already thinking about, like, not only what are we eating today, but gosh, what am I eating at the end of the week? And then what am I thinking about next week? They're already way ahead of me. And I'm like, not even thinking about today, right? So they're very far ahead. And the satiety is like how much you eat actually at a meal. Like, are you eating a small, a medium, or a large portion to feel full? So that's how I think about those two concepts. And so GLP-1 that exists within us, that regulates that hunger and satiety signal within our brain and within our gut, is on board. For those of us that have more of it, that are born with more of it, you can imagine, like I said, we regulate a much leaner phenotype, mean a leaner body type. And those of us that maybe have less of it, we unfortunately carry more adipose or fat mass. Okay, so that's the easiest way to explain it.
Jan, go.
Okay, so Albert, who's with us, obviously has talked openly and honestly about being on this drug for how long now?
God, since the pandemic. So what, 3-4 years?
Yeah, okay.
Yeah.
And you have said, like, my understanding of the drug is it quiets the food noise, right? That's a simple way of saying it. But for Albert, I've never gotten the sense, and this is no shame on Albert, but like I've never gotten the sense that the noise has been quieted at all.
To us, it seems like the noise is constantly.
It's not muted, it's quieter.
No, but it seems like it's very loud.
It's quiet.
You talk about food all
No, but
the
I
time.
also think, as you were saying that, I think my whole childhood.
I could see you.
But everybody,
I
you
saw
understand
you start
this.
fantasizing about
the
what you were
Italian
going to eat.
Americans, when you're at lunch, you're talking about dinner. When you're at dinner, you're talking about breakfast. You're always talking about the next meal. That is a learned behavior. That is
very much.
Well, but let me interject
Yes.
here.
Okay.
I want to think about this is really, really important because these medications, and this is really important because Kelly, you said this at the outset of the show. Do these work for every single person? Is this miracle? Absolutely not. That's really important for me to say at the outset. So this pathway may not be dysfunctional in persons that try it. And so when we're wondering why is someone not responding, it may be that may not be the pathway of dysfunction. So there are other medicines that are around that have been approved by the FDA. Let's go back to an oldie but a goodie like phentermine. Phentermine was first approved by the FDA for weight regulation in 1959, okay? Phentermine stimulates something called norepinephrine within our brain. So maybe that's the dysregulation, that pathway is dysregulated. What about another medication called topiramate? Topiramate, Topamax, some people call it Dopamax. It can be used to treat migraine, headaches, things of that sort. That stimulates GABA, which is gamma aminobutyric acid. I like to say fancy words. It makes me sound smart, but
You know what? It's well, we're writing them down so we
Yeah.
can sound smart later.
No, but that stimulates GABA within the brain. Maybe that's the pathway of dysregulation for this individual. But so different pathways may be the cause of dysfunction. So some people respond to phentermine, topiramate combination. That's a medication approved by the FDA. It's called Qsymia. Okay. So maybe that would be a better agent. Maybe there's another drug called bupropion. A lot of people may be like, wait a minute, is that my antidepressant? Yes, it is approved as an antidepressant. It's approved in combination with another agent called naltrexone. It is called Contrave. That combination of medications is another pathway that may be a pathway that causes weight regulation, completely different from the GLP-1s. That may be a pathway that may be more useful to an individual. And so the whole point is that as we're thinking about weight and weight regulation, all of these are mostly working on the central nervous system, which is in the brain. You can understand that not everyone needs the same recipe. Think about it, you going into a restaurant, right? And someone likes this recipe over here and another person likes this recipe. Different people need different combinations, right? Because our pathophysiology is different. It's what makes us unique. It's what makes us human. And as I'm treating my patients, I realize that this person needs a little sprinkle of this, and this person needs a little sprinkle of that, and this person needs a little sprinkle of this. And guess what? Some people need a little sprinkle of all of it. You know, I need to put it all in a big stew, right? So that's, I think, what's really important. And so as I'm thinking about kind of what you mentioned, Jan, about Albert, do you go by Albert or Al? What do you like?
Albert.
To become?
Either one. Whatever you prefer.
Yes.
I was thinking about a little Al Green situation.
Oh, I love
Yeah.
it. Go with that. That's great.
But if we think about it, maybe Albert needs a little, maybe that pathway alone is not adequate for him. Maybe he needs a little touch of this or a little touch of that or a little touch of this or what, or some.
He heard you say the words. He heard you say the word stew. I know that.
No, the drugs have worked. I mean, I started on Ozempic, lost 10 pounds, switched over to Mounjaro and lost another 20. So 30 pounds altogether. It clearly works. It's quieter. What it does mostly, I find, is it really, in the middle of a meal, which I never used to stop eating before, I would clean the plate. Now I'm stopping sometimes halfway through a meal and thinking, oh, I'm full. Or like the other day.
Yes, you and I actually shared a meal.
We shared a meal.
Everybody was astounded by that.
Yeah. And
they'd never seen Albert share before.
And I didn't even finish it, like the half when we split it.
Well, that was a lot of food.
It was a lot of food.
I mean, that was food for 7 people.
But it definitely has worked. I just don't know that it's done. It's not like the miracle where it's muting the noise in the brain.
But for our listeners who may have tried Ozempic, and
Right.
either it didn't work for them or they didn't feel well taking it or what have you, whatever the list of, it's non-efficacy for them. There are other pathways in. To me, it sounds like, because I just went through menopause not too long ago, and I remember when
Weren't you excited, Kelly?
I was thrilled. But when I
felt
started doing HRT, it was experimental at first. It was like, it's not a one size fits all. It's like you've got to figure out how much estrogen you need, how much progesterone you need. You've got to figure out the right combination, and it's very individualized. And it sounds like what you're saying is that if you are looking to lose weight via medication, it's also very individualized.
Everything is very individualized. I mean, I saw patients today. I saw about 20 patients. I before the show, for those of you who don't know, I was running over to get on air, literally from my patients. And there is not one patient that I saw today that had the exact same need or combination or response to therapy, whether they were on these GLP-1 medications, whether they had undergone bariatric surgery, whatever it was, there was no person that came in that was exactly alike. And I think it's really important for us to recognize that when I'm seeing patients, that I don't expect that anyone that comes through the door is going to be exactly like any other person. And so I have to tailor therapies to fit the person in front of me and recognize that there's going to be heterogeneity between person from person to person. And I also have to let them know that when we start any therapy, that I don't know exactly how they're going to respond. And they have to be willing to recognize that we may have to modify therapies along the way. And most of my patients have been with me for a long time, most of them for a decade or more, which speaks to the chronicity of this chronic disease that is obesity.
But so it's Jan, just speaking of that, what about, because people can buy this now online, you see it all over Instagram, like people are just buying it and taking it. So is that scary to you?
Safe?
I would say no. So when I'm caring for these patients, I'm monitoring them very closely. I'm checking for side effects. Every potential drug has its potential adverse effects. And I want to know what's going on with my patients. Patients, obviously, once they get titrated up on medications or stable, I'm expecting them to be fine. But let's say they're titrating up and they have something that happens. If they end up needing some acute medical care and attention, I'm privy to what potentially could be the side effects. We know from the trials. So semaglutide trials, semaglutide is the trade name for Ozempic, which is the trade name for patients with diabetes, Wegovy, right? That's that drug, or a Mounjaro ZepBound, which is tirzepatide. I know what to anticipate. I know what are the most common side effects to what are the most rare side effects. But if we're looking for something that's potentially online, I don't know what to expect from those things. Is it something that I wouldn't anticipate? What are the doses? Patients will come in and say something like, I'm on whatever dose. I'm like, that's not even a dose of something. I don't even know what that is.
Well,
and so that's really important for us to consider, because I need to know what to anticipate. What if I'm called from the emergency room? What if I'm paged? What do I need? What is my guidance that I'm going to give them? I have over 2,500 patients on these medications, so I should be able to anticipate what to expect. I'm a principal investigator on trials that are upcoming for medications that have yet to be approved. So I should be privy to what's going on. If I'm not able to give you that guidance, then who can?
So we, just as expected, the phone lines are blazing. So we're going to take a caller before we have to take a commercial break. So let's get to Jennifer in Daytona. Hi, Jennifer. You're on with Dr. Stanford. She's standing by and ready to answer your question.
Hi. Thank you for taking my call. I've been on ZepBound now for about a little bit over a year and a half, and I'm just about at my goal weight. I've lost about 125 pounds.
Wow.
And my question is, and it's worked wonderful for me. My question is, do you have any recommendations for titrating down or hopefully coming off of it at some point?
Thanks so much for your question, Jennifer. So one of the key things about these medications, and we've actually done trials, actually Louis Aroni, who's at Cornell, ran this trial specifically on ZepBound, which is tirzepatide. And the studies indicate that when you titrate off of the medication, about 85% of the patients will regain all of their weight. So I just want to make sure that you're aware of that, because these medications, you're on what's called a dual agonist. It's a combination of a GLP-1 and a GIP. And for those that are listening, we haven't talked about GIP. GIP stands for glucose insulinotropic polypeptide. So it's a more potent medication than just semaglutide, which is your Ozempic Wegovy. And when we pull you off of that drug, we're no longer acting on those brain pathways or those gut peptides that you are now giving yourself. And unfortunately, when we pull back on those medications, just like if we were to take away a cholesterol medicine, or just if we were to take away a blood pressure medicine or anything else, your body will go back to wherever the state was before you were taking the medication. So these are meant for chronic use. And when you pull them off, now there are about 10 to 15% of patients that will not regain all of their weight. Who are those 10 to 15%? We don't know. So you might be in that 10 to 15% that's able to maintain, but that's a gamble that you will be taking. And so I just want to let you know that that's what the studies show, and is what we see in real life for patients that do try to titrate off. Someone like yourself that's lost 125 pounds, that's a tremendous amount. That's equivalent to what we see with like a bariatric surgery response. And so I just want to make sure that you're aware of that.
I have a question, Jennifer. Is there a reason that you want to titrate off? Does your doctor want you to titrate off? I'm just curious.
Money aspect of it.
Okay. Yes,
because I do have to pay monthly because the insurance doesn't cover it.
So it is pricey. So you're probably paying, Jennifer, $500 a month if you're going through Lilly Direct. Is that correct?
I do $550 because I've been using their discount cards so far, but I may switch over to the Lilly Direct soon.
Yeah, so it'll drop it just by $50 a month. So it is
Why
pricey.
don't insurance companies cover this? Why isn't there an affordable way to have this covered for people that really are struggling with obesity?
Oh, well, you're going to get me on the soapbox, Kelly. I'm going to have to.
I know. Sorry.
I think that, companies still don't believe obesity is a disease. Or if they believe it's a disease, it's one that's too expensive for them to cover, because too many Americans have this disease, right? We're talking about over 200 million with this disease, and they don't want to have to pay for it because they see it as pricey, and the price tag is high. So, Jennifer, I don't like the price tag. I wish it were lower. What I will say is that, and like hopefully we'll get to this during the show, is that there are some oral options, orforglipron, semaglutide at high dose, that will likely be coming onto the market at some point in the near future that will likely help bridge patients that are unfortunately having to, bear the brunt of this high cost for the medications. And hopefully that will help you to maintain some of the weight at a much lower price point. But I'm very, pleased with what you've been able to achieve, and hope that you'll be able to stay on therapy. Thanks so much for sharing your story.
Yeah, Jennifer, also, just one more quick question. I'm just curious, were you able to develop like any habits, like exercise habits, walking habits, meditation habits, anything along that line that may, and Dr. Stanford, correct me if I'm wrong, but that may aid in, the assistance of coming off a medication like that?
Yeah, I typically work out about 45 minutes a day. And then I know exactly what I eat every meal for the most part. So even if I, spread a shot out maybe for 2 weeks instead of one, I know what I'm supposed to be eating, so I tend to not eat over that, or at least try to.
Those sound like good habits, right, Dr. Stanford?
Yeah, and actually, a lot of my patients that come in actually already have these habits, but their body has just not responded to these lifestyle modifications, which is why we needed to put them on therapy to begin with. I had a patient today that I saw who I started on therapy, who has a workout regimen that would run laps, no pun intended, around almost anyone that I can name, and has had these habits for 12 years, but their body has been unresponsive to these habits. And so I think, we need to recognize that many of the people that are venturing, particularly patients that have had, excess weight for quite some time, have really tried to implement these lifestyle measures and have had them, but their body has been unresponsive to those lifestyle habits alone and have really needed additional assistance, like Jennifer here, for example, who needed pharmacotherapy to help complement that. So Jennifer, I really applaud the lifestyle modifications that you're doing. And like I said, I really hope that you're able to remain on therapy, and hope that Lily's listening to really the struggles that you're having in terms of really, maintaining this therapy.
Jennifer, thanks so much for the call, and best of luck to you. We're all pulling for you. Dr. Stanford, will you stick around? We have to take a commercial break, and we'll be back. Okay, we're back with Dr. Fatima Cody Stanford. She is telling us all about GLP-1s and other weight loss medications. Let's get to another caller. We have Ann in San Diego. Hi, Ann. You're on with Dr. Stanford.
Hi, Dr. Stanford. Hi, Kelly. I watch you every morning.
Aw, thanks.
You're welcome. I have been on Ozempic for about one and a half years, and it's done well for me. I do notice that I only finish half of my meals. I have lost weight, and my doctor does check my blood work like every 3 months. But at one point, I found a lump in my neck, and I was sitting there watching the Ozempic commercial, and it says, if you find a lump or swelling in your neck, call your doctor. So, of course, I did that right away, and he said, oh, that has nothing to do with Ozempic, blah, blah, blah. It's gone away since, but I'm just worried about all these side effects that people might be getting. And, I'm glad I've lost weight and I'm still on it. I wonder if I will ever be able to get off of it, though.
Okay, so Ann, your question is it about the lump? Is it about side effects?
No,
and
it's about, I'm concerned, yes, I was concerned about the side effects, but will a person ever be able to get off of the Ozempic and maintain it?
No.
Oh man,
Yeah.
So it's a
Wow.
lifetime.
Yeah, so this is a chronic use therapy for a chronic issue, which is the treatment of obesity. And when you get on the medication, right, it is upregulating GLP-1 that you would normally have in your body. If you were listening a little bit earlier, I talked about some people have more GLP-1 on board in their body, and so they defend a much leaner set point for their weight. And for those that don't, they need for us to administer it, meaning you take a shot on a weekly basis. When you pull yourself off of the therapy, what you'll notice is you'll start to regain weight. And it's not at any fault of your own. It's not that you're doing something wrong. It's just that you no longer have that additional GLP-1 being administered. And so you'll start noticing more hunger, you decrease satiety over time, and you'll start gradually regaining the weight just because you no longer have that additional GLP-1 on board. And so it's not your fault. It's just a issue with the GLP-1 that seems to be working for you. You've been on it for a year and a half is what you just told me in the outset. And that's just unfortunately what happens with the use of these medications.
Jan.
Yeah, but talking about those side effects, I've been reading like good side effects and bad side effects.
Okay.
Can we talk about this
Take
for a
us
second?
through the side
What are
effects.
some of the good things you've seen besides the weight loss?
Yeah, so let's go through the good things. I can take you through both. Let's do that pretty quickly. So some of the things that we've noticed is that we've seen decreased alcoholism. So a lot of people have noticed that, hey, I just don't want to drink alcohol. People that may have had a really tremendous taste for alcohol, they may just decide, hey, I don't want to do that. Other behaviors that seem to have been affected, maybe they've had a gambling side effect, or maybe they've wanted to gamble. They don't want to do that. Decreased shopping, things of this sort. But we've also been noticing some potential positive benefit for neurodegenerative diseases like Parkinson's, Alzheimer's disease, things of this sort. So they're starting to investigate for these types of conditions. So we're starting to see some really positive benefits in domains we had never considered. Also inflammatory conditions like gout, rheumatoid arthritis. We're seeing major positive benefits for reducing inflammatory conditions along those domains. So those are some positive benefits. Now, there still needs to be tremendous amounts of research for us to really see all of the potential effects and for us to see those medications being used exclusively for those conditions, but those are some positive benefits. I'm not going to just rattle off all the positive benefits. Let's look at the side effects. The number one side effect associated with the use of these medications is nausea, nausea, nausea. I said that 3 times because about 40% of patients going on these medications will experience nausea. Behind that, the next thing would be constipation. These medications do slow movement through the GI tract, okay? Delayed gastric emptying is what is associated with the use of these medications. So that's something to note. Now, you would think that if I say constipation, I wouldn't come behind that and say diarrhea, but there are some patients that will say, hey, I have some diarrhea. So that's something. What about fatigue? Some people will notice that they have some tiredness. So fatigue is something that patients might notice. So that's something that we might pay attention to. These are some of the things that you might think about when you're using these medications. And so I just want to kind of put these out. So there are other things that you might get into, but these are some of the things that I will immediately mention with patients.
I just read on Instagram. So take this, what I'm about to say, how you
With
will.
a grain of salt.
I
Okay.
read on Instagram that people are experiencing blindness, just waking up blind.
Oh, no. So that's not. And so interestingly enough, out of Mass Eye and Ear, which is part of the Mass General Brigham, which is where I work, there were some studies looking at some eye changes associated with patients that actually have a history of type 2 diabetes, not necessarily just blindness, but changes within seeing and conditions associated with, I guess, ophthalmologic changes. But it's important to note that patients that have type 2 diabetes have end organ damage. It affects eyes, it affects kidneys, it affects legs, etc. And so I would be very, very careful in what you read on social media and look at the studies that are coming out from Mass Eye and Ear that actually were a retrospective chart review, which is also, we need to be a little bit suspicious because it wasn't like what we call a study that's looking forward, like taking patients that are on the medication and then those that were not on medication and looking at what do we see in terms of ophthalmologic or eye changes associated with the medication. So just be very cautious about what you're reading with regards to that.
What percentage of your patients, just quickly, because we didn't cover this, are diabetic, and what percentage are you prescribing it? Yeah. So in terms of my practice, I would say about 1/3 of my patients have type 2 diabetes. And then that means about 66% have just obesity without having type 2 diabetes. Those patients would be on Ozempic. So Ozempic is the semaglutide labeling, or Mounjaro. Okay. So that's the single agonist, which is just a GLP-1 versus the dual agonist Mounjaro. And then, of course, the labeling is Wegovy for patients with obesity, or ZepBound for patients that have obesity. So it's the wording in terms of, and the dosing does differ. For example, for semaglutide, so Ozempic goes up to a 2 milligram dose, and then for Wegovy it goes up to a 2.4 milligram dose. The dosing for Mounjaro and ZepBound is exactly the same. So those doses are 2.5 milligrams, 5 milligrams, 7.5 milligrams, 10 milligrams, 12.5 milligrams, and 15 milligrams. Albert, what are you taking?
I'm on the highest. I started on the lowest.
You started on the lowest,
and then every 3 months I would go back and get tested, and then I would go up.
And technically, we can titrate up every month. So the quickest you can move up those doses
Maybe that was
is
what
you
it was.
can
I
stay
apologize.
as
It
a
wasn't.
month.
I'm sorry.
Yeah.
The testing of every 3 months was for the A1C, right?
I'm pretty sure Ann hung up on us. But I wanted to thank Ann from thank Ann from San Diego.
Thank you for all the information.
Oh, you're still there. Okay, great, Ann.
Okay, bye, Ann.
Thanks. Good luck to you. We have Samantha from Minnesota who's on now. Samantha, hi. You're on with Dr. Stanford. What's your question?
Hi. So I was on Wegovy for a little over a year, and I had lost a lot of weight, like at least like 40 pounds. And then, but during that time when they were taking my blood, my like liver enzymes were really high and stuff. And they said, well, that, that can happen, not a big deal. Well, then they stuck me on Manjaro and I got a bowel obstruction. So now I'm not allowed on any of it. But my liver labs are still crazy out of whack. Is that normal?
So that's a very good question. Oh, I'm sorry. You were still talking. I apologize. I cut you off. Go on.
Oh no, I was just wondering, like, is that normal? Is that abnormal?
So very, very good question. So I have seen some patients that have had transient increases in liver enzymes. For those that are listening, your liver enzymes would be your AST, ALT, and your alkaline phosphatase. If you guys go back and look at your labs, you may not be sitting around thinking about these numbers, but I do have to think about them. And so we typically see these resolve over time. I don't see this very frequently with patients, but I have seen some elevations that may sometimes occur, and they should normalize if you're off of the therapy. I don't know how long you've been off of the medication, but we should see this improve. The bowel obstruction that you may have developed, like I said, we talked about that slowness of gastric emptying that occurs with these medications. And so you may have developed that bowel obstruction as secondary to that issue. And so it sounds like you're no longer permitted on the medications because of that issue that happened. That's a separate issue from the liver enzymes. How long have you been off the medication?
Well, I've been off for like the last 3 months, and the liver it's still wacky. So they said that like maybe like the GLP-1s induced it, and now we're having just trouble bringing it back down. Like sometimes like the enzymes will like come down, but like the bilirubin will be up really high. You know what I mean? Like it's just like it's not figuring itself out.
Yeah. So I would give it a little bit more time. 3 months is a pretty short duration for it to resolve. I would actually give it, believe it or not, at least a year for it to see significant resolution. And make sure you're working with a hepatologist in the middle of all of this. So that's a liver doctor specifically to make sure that they're following your liver enzymes closely during all of this. But that's a doctor that specifically works with the liver, and not like someone that is not a specialist in that domain. And I don't know if you're, working with a doctor in that domain specifically.
I'm not. I've been working with GI and
get a GI hepatologist. Like there's GI, and then you want a specific liver doctor in like a special GI doctor that works, which is a hepatologist in the GI domain. Does that make sense?
Yep, absolutely. Thank you. I appreciate that.
Yeah.
Samantha, thanks so much for your call. Good luck to you.
Thank you.
We've got Sue from Michigan. Sue, you're on with Dr. Stanford.
Hi, doctor. Thank you so much for taking my call, and Kelly as well. I have read, of course, again, like you said, don't believe everything you read online, but that you can get the medications so much cheaper in other countries like Mexico. Well, we're going on a Mexican cruise soon.
Can I Venmo you?
Heck with the souvenirs. I'm going to get to Wegovy. But are they regulated there? Are they cheaper? Can I just go over and get something OTC? Do you know anything about that?
So that is, first of all, you are right that the medications are priced considerably lower in several countries, including Canada, the UK. I haven't had any of my patients go to Mexico to get the medications. Typically what's needed, like I said, I don't know specifically about Mexico, but typically what's needed is you need a doctor in that country to prescribe the medication. So you would need someone with a license to prescribe in Mexico, or so I can tell you with Canada, in order to get the medicine in Canada, you need to have a doctor that's licensed to practice in Canada to get the medication. Because, for example, the price point in Canada is about 1/5 the cost here in the United States, but you would need a doctor that has a Canadian license. For example, I only practice in the United States. I don't practice in Canada, so I wouldn't be able to prescribe the medication for you to go to Canada, for example. I presume the rules are the same for Mexico, but like I said, I don't know specifically. I hear what you're saying, and I like what you're thinking in terms of access, but be thoughtful in terms of whatever their rule structure is. I will tell you that there are some pharmacies that will ship directly with your doctor. For example, I do use a pharmacy in Israel for my patients that ships directly to my patients here in the US. The price point is slightly cheaper than the pharmacies here in the United States. It does allow a US doctor to prescribe to Israel and to ship here to the US, not significantly. Like I said, it's somewhat cheaper, but not significantly cheaper. So I would just check what the rules and regulations are for Mexico specifically.
Sue, just thinking outside the box here and spitballing, have you considered taking a Mexican doctor as your plus one on the cruise?
Hey, that is a great idea.
Isn't that a great idea?
You got to meet somebody soon.
And me as your plus two.
All right, Sue. Well, good luck. Good luck with everything. And listen, if you pull this off, will you let us know over at Radio Andy? We would love to find out how you make out on this cruise.
Yeah, I'm gonna go the first pharmacy. I'm gonna head right there and check it out and see what's going on.
I mean, what's the worst that could happen? You just ask, right, Dr. Stanford? I mean, just ask around.
I think that you could probably find out before you go. Like I said, I know the rules for Canada. I know the rules for France. France is similar. France, you need to have a doctor that's licensed in France to get the medication. So just find out before you go, and don't be caught off guard.
All right, Sue. Exactly. Good luck to you. Thanks for calling.
Thank you for everything, ladies. All right, bye-bye.
I have a quick question before we get to our next caller, because I read today in the news that they're about to, or Eli Lilly is making a pill version of GLP-1s.
Yeah. So let's talk about that. So that medication is orforglipron. It's a non-peptide oral GLP-1. The results for that trial came out. The ATTAIN study came out about 4 or 5 weeks ago. And it has not yet been approved by the FDA, but it's showing about 13% total body weight loss with the use of that medication. We do think the price point for that pill will be significantly less than the injectable agents. And I do think that it will be a great addition to the armamentarium for GLP-1s. And I'm excited about the potential to be able to prescribe that for my patients. It will obviously be a pill, so it will need to be taken daily, unlike the injectables, which are given on a weekly basis.
I have a few girlfriends that have always been thin, but have in recent years gotten noticeably, I would call them very thin, super thin. And I'm like, what are you doing? Are you on some, what's the routine? And they told me, oh, it's nothing. I've just been taking peptides. Is peptide, are they code talking me? Is that code?
I think they are.
Right.
I think they are, Kelly.
Right.
I'm just going to say I think they are, but I won't go further.
Okay. No, I got it. I think
they're using language.
Do we have to take a break now?
Yeah, we're going to take a break.
Okay, you know what? We've got so many more callers to get to. All right. Stick around, everybody. We are going to get to you. We're going to be back with Dr. Stanford when we return. Stick around. We are back with a leading voice in obesity medicine, Dr. Fatima Cody Stanford. She's ready to answer your questions. We've got Tracy from Allentown on the line. Tracy, you are on with Dr. Stanford. What's your question?
Hi, Kelly, and hi, Dr. Stanford.
Hi.
Just want to tell you, Kelly, you're a favorite in our household.
Aw, thanks, Tracy.
Myself and my son. My son was a dancer on your show the one day.
Oh my gosh, amazing royalty in the house.
Yeah, and then he did it the safari act during your break.
Incredible.
Wow.
Sounds like my cup of tea.
Yeah, we watch you all the time. But I'm really glad you're doing this. Just in June, I was diagnosed with diabetes 2. And my doctor put me on the Ozempic for not only the diabetes, but for being slightly overweight. And I keep hearing all this about Ozempic face. And by already being older, in my 50s, that concerns me with everything always drooping down. So how do you prevent getting Ozempic face?
All right, my love. That's my southern roots coming out for a second here. First of all, I don't want you to be worried about that. We got to take care of this type 2 diabetes, which, is a coronary equivalent. By that, when you develop type 2 diabetes, we call it a coronary equivalent because it's the amount of damage that's been done on your body once you get that diagnosis is as if you've had a heart attack. So I just want you to recognize that that's going to be number one to acknowledge, okay? So number one. Number two, when we look at this idea of Ozempic face, first of all, that's just something that was coined by social media. Whenever we lose weight, whether it's from lifestyle, whether it's from medications, whether it's from surgical interventions, we lose fat mass. We carry fat stores in our face. You can't see me. I'm pinching my cheeks. I kind of have the same cheeks I had when I was 3. I'm much older than 3, as you might know. We lose fat a lot of times in our face. And so this idea of Ozempic face comes from the fact that when we lose weight, we can lose it from anywhere, but we can lose it in our face, okay? So we lose it in our face. And so people may say, oh gosh, you have this idea of Ozempic face, but that can come from anything. It doesn't come from Ozempic specifically. It comes from any time you lose weight. And if you lose a large amount of weight, whether it be from medication or, like I said, lifestyle modifications or surgery, you lose a lot in your face. So don't be discouraged from using medication for that reason. I want your heart to be healthy, and I want you to go on the right therapy to treat that first. So don't be concerned. And another thing, you said 50 is old, and I'm way too close to that for this to be old. I tell my patients they can't tell me they're old until they're 80. So I want to correct that also. So that's a really important note to think about. So I want us to kind of rectify that as an issue. So that's not really a thing. I understand that it's been popularized by social media, but it's not really specific to Ozempic. Does that make sense?
Yes. And my doctor has me also on metformin because, okay, which one does for the kidneys and one is for the liver, correct?
Not necessarily. So metformin is in a class of medicines called abiguanide. You probably haven't heard that because metformin's a oldie but a goodie. Metformin is complementary. It's usually first line for patients with type 2 diabetes. And believe it or not, metformin augments your own body's GLP-1. So it kind of is complementary. We can't use metformin if your kidney numbers are too low. So if your creatinine was below, a certain number, or GFR, is below a certain number, we can't prescribe metformin. But these two medications, if you're on a GLP-1 and metformin together, can work really synergistically. They work well together. And so often you'll see those two medications prescribed together very nicely.
Okay, yeah, and they have me with a diabetic dietitian. And so, I have a whole field of doctors.
I love that.
My whole thought process was it runs in my family. I don't want to get to where my parents were with insulin and chronic kidney disease. So I'm trying to nip this in the butt right away.
I love that.
My husband wants to know if I will ever be able to stop Ozempic.
And so no, that's been a kind of a chronic theme for us today. If this medication is being used to treat type 2 diabetes, it's a chronic use therapy. You don't come off of the therapy, and you would use that chronically along with that metformin in conjunction with that long-term to treat your diabetes and also the excess weight. So no.
Trace, are you still there?
Yes. Hello?
Listen, don't worry about anything except getting your health right. Yeah. Don't worry about anything else. And there are so many cosmetic procedures that are available. If you listen, I am your girl. I'm your go-to.
It's like 3 episodes above this.
Yeah. Go back 3 episodes, and you can listen to all the ways you can combat any sort of weight loss. Okay.
Okay.
What about hair loss? Because I hear about hair loss.
What about hair loss?
Yes, hair loss. So hair loss is very common with these medications. A lot of times you're losing so much weight that the hair follicle itself is affected. So for many of my patients that this happens, I will often prescribe minoxidil. You guys want to know what minoxidil? You remember those Rogaine commercials from back in the day? It's the same ingredient that's in Rogaine, okay? But I can prescribe it in a pill format, usually starting at 2.5 milligrams. It goes as high as 10 milligrams, but you will become a hairy girl if I go to that. So we start at 2.5 milligrams, and usually that's enough to get things going. We can also use a topical, meaning something like a topical Rogaine or a topical biotin. We can take it with biotin also. Biotin is actually vitamin H, as in happy. So we can use that along with the minoxidil. Minoxidil is prescribed if we use it in a pill format. And we can use a biotin infused shampoo, whatever your favorite brand is, to help with the issues with regards to the hair loss. Okay.
Okay, let's get to Monica in Palm Desert. Lucky Monica in Palm Desert. Monica, you're on with Dr. Stanford.
Hi, Kelly. Hi, doctor. Thank you so much for taking my call. Kelly, you are my Oprah, and I love you to death.
Oh, my gosh. That is the nicest thing anyone's ever said to me. Oh, my gosh. That's our new tagline. Yep.
Yeah.
Thank you, Monica. What's your question for Dr. Stanford?
My question for the doctor is, I'm in full-blown perimenopause, and I have some stubborn 10 pounds, 15 pounds that I've been wanting to lose, so I know I can't get on the official GLP-1, but I've seen there's a nutrition supplement that I buy, but I haven't bought this. It's a Fiber One GLP-1 booster. I don't know, does it work? Is that real, or is it just a gimmick?
Okay, let's talk about these things that are labeled as GLP-1 boosters. It is a gimmick situation because they just want to put GLP-1 on the label to entice you because it's like, ooh, that sounds fun and exciting. Anything that's labeled as that is, if it's not an actual GLP-1, it's not that. However, let's talk about fiber. Fiber improves satiety, which means that it's going to work in a way that mimics what they're trying to say is this GLP-1 like booster, right? We want to improve satiety, and fiber works on that. Perimenopause, however, what happens with perimenopause is we see a decline in estrogen and we see an accumulation of adipose or fat mass around the midsection, which is what you're probably dealing with, which is very common as we go through that menopausal transition. And so you're like a little bit upset about that situation, as all women are, as we go through that. No matter how lean we are, we can go through that transition. You can increase your fiber intake by not necessarily using this gimmick. You can just increase or boost fiber. One of the key things that I think is a really great strategy is one of the things that one of the dietitians from back in the day, Tammy Flynn, put out, the 3-apple plan. Eating an apple prior to each meal, if that's one of the things that you want to use. You don't necessarily have to use this Fiber One plan. So a GLP-1 booster, like I said, is a gimmick.
You know, Monica, also I would go to an endocrinologist or a hormone specialist and have your hormone levels checked and get your thyroid checked. Because I know, like we were talking about this before this podcast started, but I went through menopause during the pandemic. So imagine you're me and you're going through menopause, and also every gym is closed and everybody's just sitting around eating cereal. And very quickly I gained 12 pounds, which doesn't sound like a lot, but I'm a really small person. So for me, that was a lot. And it took me almost 3.5 years to take it off, and it was like a lot of diet and exercise, like a lot of really sensible eating and devotion to exercising. But none of that would have made a difference, I don't think, if I didn't start doing hormone replacement therapy.
Okay. Well, thank you very much. This has been very helpful.
Really? Oh, I'm glad. Yeah, good luck to you, Monica. And at the end of the day, you live in Palm Desert. I mean, come on.
Monica, have you been to Eddie V's seafood place?
Well, of course. And
Dr. Stanford, you say that
It's always about
It's
food.
famous.
Yeah.
It's seafood,
Always
though.
about food, though.
no, but
It's
you
healthy.
see the food noise. Some medical earplugs aren't
She's
big enough.
been.
He
She
needs
said
a
she's
different
been.
pathway.
It's seafood jam.
You need a new pathway.
Different path.
Albert, what do you eat when you go to Eddie V's Seafood?
Oh, I think I had a lobster tail. It was delicious.
Did you dip it in the butter?
And I had a martini. I may have, I don't know. Actually, I think I did. It was drawn butter. Listen, Monica understands. She knows.
Monica, thanks for your call. We really appreciate it.
Thank you.
So, I really feel like, Dr. Stanford, you gave people really important, honest information. I was surprised, as I think the callers were, and I'm surprised their doctors didn't like sort of inform them of this, that they are going to be on these medications for the rest of their lives. I think that was a big surprise to a lot of people.
Yeah.
But you gave everyone a lot to digest, pardon the pun.
And that could change, right? I mean, that's just what we know as of now, correct?
No, that's not going to change.
It's not going to change. Okay.
No.
Going to change.
No.
Well, I really appreciate you answering so many great questions, giving us all the answers that we needed. Everybody, give it up for Dr. Fatima Cody Stanford. And we'll talk to y'all off camera next week. Bye-bye. Let's Talk Off Camera with Kelly Ripa is a production of Melojo Productions. From Melojo, our team is Kelly Ripa, Mark Consuelos, Albert Bianchini, Jan Chalet, Seth Gronquist, Ross Therian, Devin Schneider, Michael Halpern, Julia Desch, and Team Radio Andy, Lisa Mantaneo, Scott Marlowe, Jake Getz.